So next is dentistry, which everybody has teeth. Our kids have teeth, so it's really important. And I know my granddaughter has gone through some issues going to the dentist, so I imagine everyone has. So we're lucky to have Dr. David Fry. He's here at the University of Texas. He's the past president of the American Association of Developmental Medicine and Dentistry. He's worked in Hawaii, go figure, Alabama, I believe, and now he's resident here in Texas. So I'd like to welcome him, and he's obviously got a question for Shefali as well. So.
All right. So I've got 5 minutes. I'll do whatever you want me to do. I prepared a 50-minute PowerPoint, so I know that that's probably not going to work for you guys. How many, I need to know my audience, how many of you have challenges with dentistry? Oh, wow, okay. How many have children that are over the age of 20? Okay. And for those that are over the age of 20, how many have had a challenge in finding a dentist that meets your needs? Okay. For you that are, your child is between the age of 10 and 20, how many of you have had challenges finding someone that meets your needs? And then for those that have children at age 10 and under, how many have had challenges in meeting your needs? Okay, and then lastly, how many have found a great dental home and you're happy with it? Okay, so I see 3 hands. So I had a really interesting conversation at breakfast with a mom who described her dental experience with her pediatric dentist, and it was wonderful. And I actually told her, I said, you should just get up and give my lecture. So I'm a developmental dentist. I also am a healthcare administrator, so I've had 2 careers. And my first 18 years were in private practice, and I come from a family with family members with disability, with autism, but also my dad was deaf. So I grew up in a disability community setting, and I kind of gravitated toward that as a dentist. And then I became the director for developmental disability services in Arkansas, followed by 14 years as the chief of developmental disability services in Hawaii. And so my background is both as a health administrator and as a developmental dentist. And I did want to make a comment. Somebody was talking about the Vineland. I don't know who it was. But in Hawaii, we use the Vineland. It's great for adaptive, trying to measure adaptive skills. There are very few tests, though, that really can correlate a person's ability to brush their own teeth. So you can find a lot of information, but it's really hard for dentists to say, oh, before someone comes in, I know what to expect. We actually shifted in Hawaii over to what's called the support intensity scale. So this is a boot camp, and I'll try to see how much interest you have, and we'll keep moving. I like to walk around, but I guess I'm going to have to stay here by this microphone. No, I might do that. So I don't know how well you can see these slides, because I'm going to show pictures of teeth. Feel free to get up and come really close, and you'll learn a lot more, because you'll see what I'm trying to talk about. But I want you to see a little bit. So this is the learning objectives. You can read those later. The American Academy of Developmental Medicine and Dentistry, which their name is changing to American Academy of Developmental Medicine. Really good organization. I'd love for your family group to really come and come to our annual meeting. Our next annual meeting is going to be in Pittsburgh next June. But I would love to see this particular meeting and our meeting co-locate. We have about 200 or 300 clinicians, and they're really, really great. The previous speaker and I were talking about some of the people on our board that she knows. They support changes. So what's really happening? And I don't know if you can read this in the back of the room, but what does happen is that people call, they find somebody that finally will take their child, and then it doesn't work. And it's because the reimbursement model for dentistry does not match well with success in treating patients that are nonverbal and that might communicate with their behavior. Okay, so the problem is the dentist misinterprets the behavior as something bad. The behavior is actually something you can learn a lot from as a dentist, but you've got to learn how to do it. So you as families, and what this boot camp is about, is how to train your dentist. That's literally what I'm going to talk about. So many of you have probably experienced this. The Surgeon General, David Satcher, in 2001, talked about the fact that for people with intellectual disability, that oral health was the biggest challenge. And in fact, the DD councils across the country continue to report this as being the major healthcare unmet need. And it's really got its basis in what I previously mentioned, is that the reimbursement model for dentistry, we only get paid when we complete a procedure, okay? And so all the little steps that people have to go through to learn to be a good patient really don't get reimbursed, and so dentists don't want to do them. Now it's also interesting to know that Congress in the United States passed the DD Act of 2000, and in it, I find it very interesting. I don't know if you can see the appropriate and sufficient, let me see here, there we go. Appropriate and sufficient medical and dental care. Dental care is actually listed, and it says appropriate and sufficient, and that's your right as a person with intellectual disability, according to federal law. I find that just interesting. The Commission on Dental Accreditation in 2018 said, okay, we need people to talk to us about this new accreditation standard. The Council on Dental Accreditation is what dentists have to learn when they're in dental school. Now, pediatric dentists do a fantastic job with children with intellectual disability for the most part. And the reason is they graduate after 4 years of dental school, and then they do an additional 2 to 3 years of education, which includes learning about how to work with children that are nonverbal. The standard, and you can read this is in your handout, so I'm not going to bother to do it, but you see all the lines through things? The big change here is that graduates must be competent in assessing and managing the treatment of patients with special needs. And the old language was, graduates must be competent in assessing the treatment of patients with special needs. Managing the treatment needs of patients with special needs. So the difference is future dentists are going to have to be trained to do this, and right now they're not. So those are the two biggest barriers. Overall, why are teeth important? Well, oral health, which includes the teeth and gums and everything between the lips and the throat, actually are connected to the rest of the body. And we know that you can get systemic disease, including cardiovascular disease, respiratory disease. There's a lot of issues, so we'll talk about that. These are the major factors that everybody, not just people with disability, but everybody needs to pay attention to. So I'm going to talk real briefly about these things. A lot of kids dupe kids can have cleft lip, usually not cleft palate, but they can have cleft lip. High and narrow palate is real common in dupe kids. And that also can be related to swallowing and tongue posture, which can also make it much more difficult to get a good orthodontic outcome if you're trying to do braces on a person. A lot of times people have really small teeth and missing teeth. If you've got seizure medication, there's issues with gum issues. So we're going to talk about these factors on oral hygiene. So when to brush, I think the most important thing is start very early making brushing a part of doing things fun. You don't have to have toothpaste, and it's really important not to use toothpaste, and it's really important to have multiple types of toothbrushes, and you make those toys. And I'm talking about infants, and you just really, the goal is not to sit down, brush your teeth. The goal is to just make a toothbrush a part of my environment and encourage people to walk around and chew on a toothbrush. I think that's important. So what is caries? Caries is just another name for cavities. It's a universal disease, and it can be fatal, and that's a shock. In 2008 in Maryland, Diamante Driver was an 8-year-old that died from an untreated dental abscess in the United States. That should never happen. And it's a bacterial disease that originally is passed from mother to baby. So a lot of people, there's 2 bacteria involved, and the bacteria feed on carbohydrate and sugar. So if you're going to forget what I tell you, I want you to remember this. If you get sugar or carbohydrate, which converts to sugar, on teeth, and that sugar gets down in the groove, and it just stays there, the sugar is converted to an acid, and that carbonic acid is what eats holes in teeth. It also causes gum disease. It's active for 20 minutes. So in other words, the saliva normally will get rid of it. So when do you need to brush? Really, you need to brush when you stop eating and your saliva glands start to shut down and the saliva flow slows. So while we're eating, our saliva glands are stimulated. So what you want to do is understand about the importance of brushing. Malocclusion, that's just about how our bite is. And so I won't go into all this. You can read it later. Mastication is chewing. Some people do a lot of bruxism. If you're noticing that your child's teeth are looking flat, you want to pay attention. Are they grinding their teeth in their sleep? Then that should be addressed. GERD and erosion are issues for adults. And I'm trying to go really fast. So fluoride. Fluoride is your friend, and I tell parents this. Fluoride is natural. It's a part of the environment. What about if my child swallows it? Then that's not good. You don't want to be swallowing toothpaste. That's why I said brush without toothpaste, at least for a long time. I like to rub toothpaste on teeth with a little finger brush and then rinse it off myself and make sure that it's a small amount. But to get a person to use a toothbrush, and the electric toothbrushes are great, I want the person themselves to use it. So if your child's affected with Duke 15Q, you want them to get used to having a toothbrush in their mouth and them do it, but without toothpaste, because you don't want them swallowing all the toothpaste. And then there's prescription gels. So just so you know that the World Health Organization said water fluoridation is one of the top 10 most important health initiatives in the last 100 years. And it does make a difference. And we can see it in communities that have it and communities that don't. Fluoride water, fluoridated toothpaste, mouthwashes, supplements, and professional fluoride applications are all ways that you can get fluoride, and you really need to know how much is enough and when is too much. So the treatment for grinding habits, bruxism is grinding habits. It's usually not related to stress, and so I think that's something that causes a lot of parents problems. I'm just not going to cover this stuff. So this is the part I hoped you could see. I tried to make them as big as I could. Have you been to the dentist and they say, oh, your child has 5 cavities, and then you take your child to another dentist and they say, oh, your child has 10 cavities, and you go to another one and says, oh, there's just a few things we're going to watch. Anybody ever had that experience? Multiple dentists saying different things? Not necessarily for a kid, right? Here's the reason why. When the dentist looks at this little spot, it can be deep and it can be shallow. And depending on how deep or shallow it is, used to make the difference in whether we did fillings or not. And that is changing. And it's changing because something called minimally invasive dentistry. We now have bioactive materials, and we can seal the tooth deep into the groove. Now, this is not Pitt and Fisher sealants I'm talking about. But I wanted you to see the extent of decay. So the dark area, this is the same tooth cut in half. And so the dark area shows how deep the decay goes into dentin. The problem is that sometimes we have these little spots and they're not very deep. So what's the buzz? What's so important about minimally invasive dentistry? Well, there's a lot of tools that we can use. So lasers is a big one that's happening. And what does that mean for kids with disabilities? What that literally means is that you might not have to use the needle, you might have to use a shot, and you can do things a lot faster, and you can also do them incrementally. So in other words, I don't have to finish what I'm doing today. I can start with the laser and maybe the next time come back and do the PRR, which is a preventive resin restoration. So is drillless filling possible? This is actually University of Texas, where I teach here in Houston, and this article was published probably 6-7 years ago. And so these are some of the people. So yeah, it's definitely possible. And here's the before. And here's using a laser. So this is my patient. And you can see the hole. Now, we also learned, because it's a bacterial disease, decay is a bacterial disease, you don't have to get rid of all of it. You just have to get rid of the most active part of it. And then you can put a liquid down in there that kills the bacteria, and then you can seal it. And so that's how it looks like after. So I just wanted you to see that. And there's the filling. Hard to see. So you can read this later, but there's a lot going on. Now, in the area of fluoride, I didn't think I just lost. So, okay. I guess I'm going too fast. In the area of fluoride, I just realized this is great. Okay, I don't have to use this now. Okay, so when we're actually working with a lot of decay, a high caries risk, you have to identify how much caries and how fast. And part of that comes from genetics. So if the parents have high caries, then maybe that's true, but it also comes to the amount of exposure. Dilantin hyperplasia comes from kids on seizure disorder with dilantin. And I'm going to just go ahead and get right into some of the treatment issues. So what I want to stress is that we really want to, let me see if I can go backwards here. So I don't see the picture that I was looking for, but that's okay. NASD is the National Association of State Directors for Developmental Disability Services. Now, NASD has come out with a position statement that says, trauma-informed care recognizes the damage of restraint. I think any approach that enhances a person's sense of values and dignity is worth a lifetime of trying. Now, dentists, remember I said one of the barriers is they have to complete a procedure to get paid. So when your child shows up in their office, they're going to say, okay, we can try this little desensitization, and after 5 minutes, if it doesn't work, we're either going to go to the OR, we're going to go to the hospital and do everything under sedation, or we're going to restrain your child, okay? And the problem with that is that for the most part, unless people are in a true emergency situation, I just fell down, my front tooth is broken, my mouth is bleeding. If that happened to anyone, if I fell down, hit my head, and I get to the emergency room and I can't communicate verbally because I've had a head injury, they're going to put me in a papoose board in order to get x-rays. They're going to find out what's wrong. In my opinion, that's really the only time you've got a true emergency. So, do people learn how to be good patients? Absolutely. Dentistry moves too quickly to restraint and to sedation, and the reason is that's how they get paid. And so what I want you to do is to learn how to be a good patient. Now, did we pass out these pieces of paper? Did Sarah get these passed out? Can someone ask Sarah to pass these out? Oh, here Sarah is. I want you guys to get this because this is basically the take-home message today. When you show up at your dentist, you want them to know what you're doing and what works about behavior. You want them to tell you what you need to be doing at home. And then you want to have a shared goal. And so you want to train your dental team. And you really do need to recognize that the way that dentists may want to do it might need to be changed. So they'll call restraint protective stabilization. And they call it a papoose board. And it can be used for the wrong reasons. And so in Colorado, the state law says you can't do it unless you try other stuff first. And it really a lot of contraindications for it. This is written in the state law in Colorado. In your handout, I gave you the Texas state law. So I would strongly caution you about not going down that road because remember what NASD said. They said it causes psychological harm. It will almost guarantee that you're going to condition a person to think of dentistry as something not good. And so if you got to the dental office and you found out, hey, by doing it incrementally, it's a lot more successful, you might be able then to, over time, get to where you really can make it work. So way before the appointment, you want to talk to the team. You want to go maybe invite the team to your home. Ask for the dental assistant to come. Interview the dental team. Tell them what to do. And is a person verbal? So these are all the things that you need to communicate to the dental office. The way we did this in Hawaii was we used the home and community-based waiver. And so we had, also with the schools, we had behavioral support plans. And so we wanted the psychologists and the BCBAs to work. And we got Easter Seals in Hawaii, and we got the ARC to hire dental assistants to go do personal care in the home. And so what we did over time is we got the dental office to understand what was really happening in the home with the person. We also brought portable dental units into the home. And so people got used to using the air-water syringe. The air syringe would blow on the tummy, blow on the hand, and this would be in the home, make toy balloon animals. But what you're doing is you're getting a person used to the tools of the trade, so to speak, and you're also you're trying to find out, okay, who at the home is doing a really good job and what's working, and you get that dental assistant to observe that, and then you do a hand-over-hand method where the dental assistant puts her hand on your hand as a parent, and then gradually you fade out as a parent, and that transfers the bond of trust. And by doing that in the home, you set the stage for more success at the dental office. But the dental office, a lot of times, you go 10 visits and they're just a tour, and just ride in the chair or whatever. Some dentists call them happy visits, but you've got to find you a dentist that'll work with you. And so that's probably the key. If you don't know what to do, ask other families. I've learned more from families than I've learned really from anything in my career. So we talked about this, and I just have to get through this slide, and I would just say that general anesthesia is $10,000, and it's not a solution. Also, repeated general anesthesia for doing cleanings and doing dentistry can cause cognitive decrease, and that's an important thing. You don't want to do too much anesthesia over a lifetime. So what are the behavioral strategies? We talked about it. Experience the environment incrementally and establish the relationships incrementally. Engage the person to be participative in the process. And what does that mean? Literally, when people are engaged with their mouth and they get used to people looking in their mouth, and they are focused on brushing and keeping their mouth clean, and you're using a lot of praise, do more than just try to brush your teeth in the morning at night, and don't hold people down to brush their teeth and make it an unpleasant experience. Make it fun. Use it in other ways. Use that toothbrush to tickle the ear. Do whatever it takes to be creative. You as parents do this all the time in all kinds of ways to teach your children. You're the people who can train your dental team, and that's so important. So if you do have a behavior, back away from the behavior. Don't force it. Figure out what was the antecedent, what triggered it, and then you say, okay, what was the communication and what was the consequence? And I'm going to go way too fast through this, but you can look at the handout. This is how you teach your dental team. You prepare the individual. I really like social stories. Social videos are available on the internet. A lot of dental offices now will provide you a video of theirs. And so I'm just going to go through this really, really fast and not stay here too long because I think I'm out of time. But I don't, because 10 minutes ago we were supposed to start it. So I'll finish up really quick. This right here is the last thing. This is a game changer. Silver-diamine fluoride, it's been around for about 20 years. There's plenty of statements. There's ways to do this. And in-home dental works. There's an intraoral camera called Mouthwatch that works. This is in your handout. And the new model is a dentist without walls. Outcomes reimbursement as opposed to procedure reimbursement is coming, okay? And so I think as we're changing dental education, we're also going to need families to help us advocate to get Medicaid agencies to change. One of the biggest problems that Medicaid agencies after the age of 18 or 21 will drop a lot of children's dental benefits. The reason they cover dental benefits as children is because of EPSDT, which is early periodic screening, diagnosis, and treatment. So there are better approaches, carries risk, an integrated care model, incremental desensitization, and just understand that you got to get it in the ISP. And I'll be skipping all of this and just realize, okay, I don't need to talk about behavior because I don't have time, but you guys have already heard a lot about it, so I think you know it. The D-Determined program, I just passed that. Let me see here. This is something worthwhile. This is in your handout. David Tassini's a dentist in Florida that developed this. It's just really a form of ABA. This is something you can get really cheap on the internet, and its specialized care company sells it, and it's something you can give to a dental office and say, why don't you guys take this home and learn this? If you have a dentist that already knows about this, they're going to look at their environment and say, what antecedents trigger behavior? What do we need to change here? So I've seen mood rooms. I've seen oral health education rooms that are not a part of it just looks like a living room, doesn't look like a dental office. All of those things are very effective. You can clean teeth have a person sit in their favorite beanbag chair, okay? You can brush teeth at home that way. You can also bring that beanbag chair, or a dentist can have one. So there's a lot of different ways to do it, and this is about training the team. Peer education works, and there's just, I'm going to just go really, really fast. The medically underserved designation was created by Congress, and your children are not included in that. They're definitely medically underserved, but they're not included. And the reason is that the current law is interpreted by zip code. And so it's designed to say if you're poor. So there is a law before Congress to change this. Now, why is it important to you to have that designation? If clinicians graduate for dental or medical school and they say, you know, I want to serve just this population, I really want to work in a clinic that just does this, they cannot participate in the loan forgiveness program for their educational debt. Dentists are graduating with $250,000 worth of educational debt, and they can go serve in Indian Health Services in Montana on an Indian reservation, and they can get that debt repaid through a federal loan reimbursement program because that population is considered medically underserved. So if you want to learn more, AADMD has a lot of information on their website. The ADA, the AMA, all these organizations have supported this. These are the resources. There's a couple of good books by Karen Raposa, who's a parent of a child with autism, and a dental hygienist, and Steve Perlman. That's it. Thank you very much.